So my research, personal research, is in lung cancer screening. I've always been focused on community-based interventions and meeting people before upstream of the health system. And so marrying a position with community outreach and engagement with leading a population science institute actually works really, really well.
Welcome to the Oncology Insights Podcast. I'm Steve Rosen, Executive Vice President at the City of Hope, the Emeritus Cancer Center Director and Director of the Beckman Research Institute, a hematologist oncologist, a clinician scientist with a focus on blood cancer therapeutics. And I'm thrilled that my guest today is Dr. Lisa Carter-Bawa, a distinguished behavioral scientist and adult nurse practitioner. Welcome, Lisa.
Thank you. Thank you for having me.
I'm thrilled you're with us, and I'd like you to start by sharing your journey, how you became a nurse, how you decided to become a behavioral scientist, and then we'll focus on your research.
Sure. That's a large question because it's been an interesting journey, but I'll try to briefly, summarize it. I actually started off as a pre-med student because my father wanted me to become a doctor. That was the metric. And I actually, when I was a pre-med student at the University of Louisville, and I got ill. It wasn't a big illness. It was like a bronchitis, and went in to be checked, and I was seen by a nurse practitioner. And it was a woman who came in, and without her hand on the door, she sat down and she took this really thorough history. This is many decades ago, mind you. And I was amazed because I had never encountered someone who took the time to ask me about all sorts of different things, not just about my cough. And I asked her what she was, and she told me I'm a nurse practitioner, and I never had heard of that at the time. And so, but it really resonated with me. And so midway through my baccalaureate program, I switched to nursing. And so I went to nursing school knowing that I wanted to be a nurse practitioner. Back in those days, you didn't go straight from a baccalaureate program, your nursing program, to graduate school as a nurse practitioner. You had to practice. It's a little bit different now, but I think we actually had a better way because you had to actually go and practice and be on the floor and get to know your hands dirty and everything before you would be allowed back into graduate school. I did that and then went back to grad school, became an NP, and actually I'm from Kentucky originally, and so from Louisville, Kentucky. Me and my partner were one of the first nurse practitioners to own a nurse practitioner owned and run clinic. And that's a whole other podcast because this was a long time ago. But I really loved research, and I really wanted to ask questions and answer those questions myself. And so I remember telling my partner at the time that I was going to go back to school. I was going to go back and get my PhD. And she looked at me dead serious and said, "Don't you remember we hated stats in grad school?" And I said, "Yeah, but I want to create new knowledge." And so I went down the road of pursuing my PhD. I very, very quickly in my doctoral program, after taking philosophy of science and theory, realized it was like it took the blinders off, and I realized how much I did not know. I felt like I was expert in my field, and I realized there was so much I did not know. And so I did a PhD followed by a postdoctoral fellowship, and it's been a road of lifelong learning. I've always been really intrigued why people do what they do. I used to tell people that I felt like I did my career backwards because when I was in my doctoral program, there were people who did go from their baccalaureate degree to their master's to their PhD, but they had never practiced. But I realized it wasn't backwards. It did me a good service because being a clinician, I ask realistic questions And what I mean by that is I'm not going to design a study that's going to have a survey with 200 items because I want to measure this, and this. I'm really interested in why people do what they do or don't do what they do. Just because we're good clinicians and we prescribe something or prescribe a treatment regimen, when we don't understand the patient perspective, sometimes we miss the whole boat because we don't put ourselves in their shoes and understand that there are multiple competing demands that might be making that decision for them, why they're doing a certain behavior or not doing a certain behavior, because we've looked in our textbooks as opposed into the people's hearts. That was more than you wanted to know.
Wisenetics turns podcast airtime into brand authority. We don't sell ads, we elevate voices. Curious how far your voice can go to become a reference in the industry and attract more leads? Scan the QR code and discover how we can turn your expertise into unmatched brand authority. Let's transform expertise into influence, starting now.
No, I love it. Can you share what your current role is at Hackensack and the Lombardi Cancer Centers, and also what you're doing on a national level?
Yeah, sure. So I wear a couple of different hats. My main position is I'm the director of the Cancer Prevention Precision Control Institute at the Center for Discovery and Innovation at Hackensack Meridian Health. So for people who don't know, Hackensack Meridian Health is the largest health system in New Jersey. We're 18 hospitals, over 7,600 physicians. It's a very large health system that covers the entire state. The Center for Discovery and Innovation is the research arm that's underneath that health system. And so 3 years ago, I was recruited from my prior position at Memorial Sloan Kettering to be the founding director of the Population Science Institute, where we focus on cancer prevention and control. But the other hat that I wear is I'm the Deputy Associate Director of Community Outreach and Engagement at Georgetown Lombardi Comprehensive Cancer Center. I know that might sound strange to your listeners, but Hackensack is a cancer center consortium with Georgetown Lombardi. So underneath the Georgetown Lombardi Comprehensive Cancer Center, we have our catchment area is the DC, Maryland, and Virginia area and the Northern New Jersey area. So I lead the community outreach and engagement. And while that seems like it might be disparate, it's actually, so my research, personal research is in lung cancer screening. I've always been focused on community-based interventions and meeting people before upstream of the health system. And so marrying a position with community outreach and engagement with leading a population science institute actually works really, really well, because that's where my personal stance from a research comes from. On a national level, I'm also very involved with the American Cancer Society's National Lung Cancer Roundtable. I'm the chair of the Stigma and Nihilism Task Group, and I'm also a member of the ACS National Lung Cancer Roundtable Steering Committee. Who
came up with the name Stigma and Nihilism? Was that you or?
I did not. So the National Lung Cancer Roundtable, we're celebrating our 9th year. So next year will be our decade of existence as a roundtable. It was originally actually the Survivorship, Stigma, and Nihilism Task Group. And if you can imagine, 9 years ago, the survivorship was different in lung cancer than it is today. And so that's why it was kind of umbrellaed under that. And the great thing is today's lung cancer is not your grandfather's lung cancer. And so we have more survivors. And so it was felt that we needed to break apart the task groups because there are survivorship, there are more survivors and there's survivorship issues that need to be addressed in their own task group. And so I think a couple of years ago it spun off. So now we have the survivorship task group and the stigma and nihilism task group. But it's intentional because stigma and nihilism are related cousins, but not the same thing.
You know, I started my career in lung cancer. Though I'm known for blood cancer research, I was a fellow at the National Cancer Institute in the branch that John Minna and Paul Bunn were overseeing. And so that's when all the cell lines were developed that led to all the major advances that we now see based on defining the targets. And actually, my first publications were on small cell lung cancer and central nervous system involvement, and then subsequently making monoclonal antibodies against lung cancer antigens, and several textbooks on lung cancer, including the history of lung cancer with a pathologist at Northwestern at the time. But for the last decades, it's been blood cancer focused for me.
Well, what an interesting way to start your career. So, yeah.
Yeah, it was. And I was at the Veterans Hospital for the first 8 years, and I came back to Northwestern, and so lung cancer was a natural. So tell us about your actual research area, what you're focused on in terms of projects. And after we talk about lung cancer, I'd like your thoughts about early detection in general, because obviously your work is relevant to the whole scope of what we do in early detection.
I did my postdoc back in 2013 to 2015, and I actually started my postdoc 6 months before lung cancer screening was an official guideline recommendation, before the USPSTF released on December 31st of 2013. I just happened to serendipitously be in the right place asking the right question, but I also had a really good mentor who was very adamant about the science that needed to happen rigorously before then. Understanding why people might make a decision to screen or not screen, or even engage in a conversation with their doctor about screening. We have a lot of wonderful work in breast cancer screening and colorectal cancer screening, but she was very adamant about the fact, and rightly so, that you cannot just take out the word colon or breast and plop in the word lung and say this is a psychometrically validated scale that we can measure these phenomena by, or conceptually, we need a theoretical model. So I did not plan to do either of those in my postdoc, but I did do those in my postdoc. I created actually, it's still to this date is the only conceptual model that's from the patient perspective around lung cancer screening. And I like to explain, because I know when people hear theory, eyes glaze over and stuff like that, but it's simply the lens that you look at a phenomenon about. It helps us understand what's driving different things that we're measuring. But so I started with a lot of the foundational work that was done. And I will tell you that at the time I felt like I was maybe behind because this was a burgeoning field. And so a lot of people were rushing to create interventions. And I was like, I want to get there. I want to create an intervention. And Dr. Rawl was really, no, you need to do this. We're going to do this rigorously. And she's right, because we can't just rush in and create an intervention that's going to help people, make a decision about screening or not without understanding what are those levers that are actually making that behavior change. So I did a lot of the foundational work. And since then, a lot of my work has been focused on the stigma and medical mistrust and fatalism in lung cancer, because unlike your other types of cancer screening that are based on maybe age and family history, as you know, lung is based on your smoking history, and smoking is stigmatized, and not just externally, but people internally blame themselves. And so there are different unique variables in lung cancer that kind of enter the picture for making a decision to screen or not that aren't necessarily present in other types of cancer. And so we've tried to be very thoughtful. My work has always had some wonderful community partners, wonderful patient partners that have helped us build. We've built a tailored, computer-tailored health decision support tool called Lung Talk that came from people telling us what was important to them or not. To give you an example, Lung Talk actually tailors on smoking status, because some of our early research, patients told us if they, people who have quit smoking don't want to be spoken to like they currently smoke, it further stigmatizes them. And so that was really, even though the content that you're trying to present is the same, the way that you frame it, the way that you message it has to be different, because you're talking from a different perspective and you're talking to different people. our whole research has really been around bringing everybody equitably around the table of knowledge to know that lung cancer screening exists. I am constantly fascinated that even in 2025, that its awareness is incredibly low. I have a study that's currently going on right now in the community. It's a community-based study where community health workers go in community-based organizations and faith-based settings and different community settings. They educate in small group settings about lung screening. And then we assess for social determinants of health. We link to resources and we use navigation to link to screening. And earlier this year, I happened to be at one of those programs. And of the 13 people who had attended the program, all 13 of them had never heard of lung cancer screening. And all 13 of them were eligible for lung cancer screening. And it's fascinating to me that if we look at other types of cancer screening, historically, 12 years out from an official recommendation, that awareness, that low awareness is not the same. And so that's one of like a lot of our vein of our research. The other thing, and I guess it's still in the same vein as increasing awareness, I currently have an R01 funded study from NCI that is leveraging social media to increase awareness around lung screening and then connect high-risk individuals to screening. So it's all about increasing that awareness, because if you don't know, how can you even know to ask or know this is an option to do that?
Can you share with our viewers what the current guidelines are?
Absolutely. So age 50 to 80 years old. You either currently smoke or you quit smoking within the past 15 years, and you have a 20-pack year smoking history. So for those who might not be familiar, you just calculate packs by how many packs of cigarettes a person smokes a day times the number of years that they've smoked. So a 1 pack per day person who smoked for 20 years is a 20-pack year history, just like if you smoked 2 packs a day for 10 years would be a 20-pack years smoking history.
And if you have an unremarkable low-dose CT scan of the chest, which I presume is the current screening, how often would you repeat it if it's negative?
You would repeat it on an annual basis or until you age out, or either age out or your smoking history is you've passed that. Although the reason I'm kind of hesitating is because the American Cancer Society has done a lot of work around that years since quit variable, and the scientific evidence is showing that if you've had exposure, that the years since quit may not matter as much as it is in the current guideline. So
the screening obviously is very sensitive, but not specific. I often have patients who have micronodules, and we follow them. In transparency, I'm on a scientific advisory board of a company called CIZZLE, CIZZLE. And CIZZLE is a mutant protein overexpressed in lung cancer. There's been quite a few publications about it. And it's a biomarker to determine whether someone has lung cancer. And so I was wondering, in terms of biomarkers now, are you involved in that work at all? Also in circulating tumor DNA, cell-free DNA, looking at multiple cancers. Does your work bring you into that domain as well? Because it seems like that's going to be the future. And I just came from a meeting involving artificial intelligence and how we apply artificial intelligence to diagnostics. And so I'm curious about your thoughts in those domains.
Yeah, so I am actually involved in a study as a co-investigator on a study that is looking at cell-free DNA as an early detection method with lung cancer. My role really is, as a behavioral scientist, really understanding like what makes what are those potential facilitators and barriers to participating in screening, regardless of how that screening occurs. And then also the patient education piece of it. How do we present and message and communicate what the test is and what it means downstream. I've always thought, obviously, the only recommended screening according to current guidelines is the low-dose CT, but it honestly doesn't actually matter what the screening test is. There's still a behavioral component that we have to understand from the patient perspective. And so but to answer your question, yes, I am involved, but it's from a behavioral scientist perspective and understanding facilitators and barriers. And from an early detection, I'm really super excited with everything that's coming out. Especially you mentioned AI. I think that there are so many things that, like I said, it's not your grandfather's lung cancer. There are so many things that have happened in just the past 2, 3, 4 years, and thinking about the involvement of AI and being able to leverage AI to really consume so much data in order to identify lung cancer before. I'm sure you're familiar with the work, Sybil, and the work that they're doing. Licia Sequest and her team are doing with AI imagery around lung scans and being able to identify cancer before it's visible. That's exciting to be able to find. Because you're a clinician, if you can find something really early, you can either cure it or you have the best potential for survival.
I'd like your thoughts. I was just at a meeting in New York. It's the Association for Value-Based Cancer Care. It's a remarkable meeting that's held annually, and it goes mainly into the best way to deliver care, but also the finances around care. But one of the sessions was on cancer diagnostics, and there was a company called TASSO, T-A-S-S-O Health, and they actually have a portable device where at home you can extract blood, enough blood to send for a biomarker. And so it's in the privacy of your home. Also, you don't have to drive great distances in order to obtain the material. And they're tying now to some of these innovative diagnostic areas. And so it'll be, from a behavioral perspective, it'll be very interesting how that affects the way people think about doing the testing. Just like historically pregnancy tests at home, which you used to have to go to your doctor's office, which was crazy.
Yeah. Now we don't even think a thing about that.
The other thing I was going to mention, years ago, I met Ernst Winder. That may not, I don't know if you know, he was the person who first said tobacco causes lung cancer, which is hard to believe that into the, 1940s, 50s, that wasn't appreciated. In fact, no. At Memorial Sloan Kettering, the doctors were still smoking. There were still ads from tobacco industry promoting the cancer center. And he told a wonderful story. He was working with a thoracic surgeon, and he showed him the data. And the surgeon said to him, we're going to be beat up about this. But he said, we have one thing going for us. And Ernst said, what was that? And he said, we're right. I'll never forget that. But it's less than a century ago that we knew that tobacco actually was the culprit.
Yes. And how long did how long, what did they try to change that narrative? So because it comes down to it, it's money. It's impact financially, financial returns. So
what excites you the most about the next steps in your career?
So I'm really passionate about stigma. That is something, obviously you heard from my intro that, where I choose to give my service and my time. And so it really, I think that we have the potential to really change that public discourse around lung cancer. I think we have an opportunity to change how it's viewed on the big screen, on the public landscape. And, stigma to me is something that is a silent killer because it impacts behavior so incredibly. People don't go see their doctor who are coughing up bright red blood because they're worried about what somebody's going to say to them, or what their doctor's going to think of them, or what they think of themselves. I've had patients tell me that, don't waste the resources on me. I did this to myself. And so being able to change those narratives and to do that through communication is really exciting to me, because I think that sometimes people, I'm not negating the bench science, the translational science that occurs, because that gives us, that gives us cures, that gives us treatments, that gives us new early detection methods. But to me, communication is really the connective tissue that forms the bridge. And sometimes it's overlooked. And so I see a lot of things that my colleagues are doing and that we're doing to be able to change those narratives. And I think they go hand in hand with the innovations that are happening. I think you're going to see a lot of that, even with artificial intelligence. So one of the things I didn't mention that our shop is currently doing is we're taking a lot of the work that we've done in the stigma space, and we are creating an LLM that is looking at, it's called Stigma Aware AI. And so it's able to go in and not necessarily replace, but be a human in the loop type of process, where in EHR notes, patient-facing communications, texts that might go out, outreach texts for our community outreach, if it senses something that is potentially stigmatizing, to highlight it and offer other ways to chart it, because the way that we speak internally, even when patients don't see it in our notes, that is part of the problem with stigma in lung cancer.
On the other end of that continuum is peer pressure and why young people start to smoke or use tobacco products of different sorts. I don't know if any of your research is in that domain.
Not specifically, but one of the things that comes to mind when you mention that is we now know, the text, I think it's called the cigarette century. We know the bad outcomes of combustible cigarettes. And so looking at like e-cigarettes and vaping, I think that kids don't necessarily know that is harmful. I think about my own son, who's now 25, but when he was in college a few years ago, I remember seeing he had my credit card, because he was away at school or what have you. And I saw a credit card charge come across that was some sort of smoke and vape shop. And so I remember texting him to say, "Are you vaping? What's going on?" And he's like, "Well, yeah, everybody does it." I said, "You do realize what's in that?" He's like, "Well, there's no nicotine in there. There's no bad chemicals in there." I was like, "Where did you learn this? You are my son. Like, did you not hear anything that I've been doing?" So I think that one of the things that I do that is a little bit concerning is I see with vaping and electronic cigarettes a same kind of arc, a narrative arc that's analogous to combustible cigarettes 50 years ago. And I don't think we don't have all the science yet. We have some good science that's coming out, but we don't have, there hasn't been enough time to see the consequences of not only the behavior that is going on, but the real health outcomes with people who have vaped for a long time.
Oh, for sure. Well, Lisa, I regret that our time is up. It's just been a pleasure talking with you.
That went by fast.
Well, you have a lot to share, and your story is just fascinating. I love it. I hope that we have more occasions to dialogue. I'm sure I'll see you now at AACR and at ASCO.
Yes, absolutely.
Yeah, and thank you so much for taking the time. And it's been a true pleasure.
Thank you for having me.